joining us virtually. Today, Dr. Daniel Blatt will be presenting, and Dr. Gary Marshall will be introducing him in just a moment. Just as a reminder to please mute your microphone, decrease the ambient noise for the presentation, and the CME code is 130403 at the bottom of this slide, and it's also within the moderator section if you have participation and the attendees. I will also be putting that into the chat throughout the presentation as well. So Dr. Marshall, please take it away.
Thank you, Addie. Can I get a confirmation that you can hear me?
Yes, we can hear you.
Okay,
yes.
Great. Okay, great. So Daniel has been with us for about a year now, but many of you might not be able to connect the name with the face with all the mask wearing and the social distancing. I don't know that today's grand rounds will help with that since we actually won't be able to see him, but at least you'll have an opportunity to listen to him and benefit from his expertise and his interests. Dan is from Syracuse, where his father is actually director of the General Pediatrics Division at Upstate Health Care Center. And I suspect that that's where he got his inspiration to become a pediatrician. He graduated with highest honors in 2014 from the University of Medicine and Health Sciences in St. Kitts, and he moved on to pediatric residency at the University of South Alabama in Mobile. He then completed a fellowship in pediatric infectious diseases in 2020 at Brown University and Hasbro Children's Hospital in Providence, Rhode Island. And then he came here in August of 2020. As a student, Dan worked at Ain Shams University in Cairo, Egypt. And later, he also spent time as a village doctor in Nepal. He helped set up a global health rotation for residents in Kibagora Hospital in Rwanda, which serves Rwandan and Congolese refugees. And he was the pediatrician for an 80-bed inpatient unit there. One of his research interests as a fellow was in severe malaria, where he investigated the role of iron therapy and oxidative stress on readmission and death in pediatric patients. He also participated in an analysis of geographic variations in response to pneumococcal conjugate vaccines in clinical trials. So Dan is a medical citizen of the world, and I know this is where his interest in emerging infections comes from, and we're going to hear more about that in just a minute. But just to round out this introduction, I can tell you that Dan is a wonderful clinician, easygoing and personable colleague, and he's been a fantastic addition to our group. He has aggressively sought community engagement in response to the COVID-19 pandemic, and he's really become one of the faces of our hospital and department on local and even national news media. In fact, just yesterday, an article ran on CNN in which Dan was interviewed and featured. I'm a little bit worried that we may lose him to CNN at some point. I could see him replacing Sanjay Gupta. Maybe that's in his non-compete clause. We'll have to check on that. But anyway, as you might have gathered, Dan is somewhat of a global adventurer. But know that he and his fiancée Meredith were just married right here in Kentucky on June 6th because, and I'm quoting him directly, "This is our new home." And so we're very glad to have Dan as part of our family and interested to hear about pandemics and how to stop the next one. Dan?
There you go.
Thank you, Dr. Marshall, for the kind introduction. I appreciate it. I'm also very happy to be here. As Dr. Marshall said, you know, I've been here during the pandemic, and I really haven't gotten a chance to have a lot of great FaceTime with most of you. And I was really hoping my first grand rounds, or I guess 1.5, I helped out back in April. I guess my first grand rounds, I wish that we were able to all do this in person, but maybe one day. But either way, I'm happy to be here virtually with you. My name is Dan Blatt, and as Dr. Marshall said, I'm relatively new to the Louisville community. I came here about a year ago. Today, we'll talk about something that everyone knows about more than they did in 2019, pandemics. But I promise I won't only talk about COVID-19. So the year is 2031, and there's a mysterious illness reported to cause severe hospitalizations in Asia. There is a new virus identified as a possible cause. Maybe you see a news headline similar to this one from a year and a half ago. China grapples with Listeria pneumonia-like illness. I certainly remember seeing that. So you may think to yourself, is this real? How did this happen? And is it going to spread here? Maybe more importantly, do I need to hoard toilet paper? We are going to discuss how a pathogen becomes a pandemic. There are more factors that go into this than I or any one person can discuss. This will not be a comprehensive lecture. There are many variables and unpredictable events that build a global pandemic. Each one can be their own lecture, and because we only have 1 hour, what I want to do today is paint a picture about what happens when global catastrophe strikes in the form of an infectious disease. But first, let me go over a few terms I'll be using throughout the lecture. So the term sporadic refers to an infrequent disease. Endemic means that a disease typically comes from a specific area. An epidemic is when we see more cases of a disease than we normally expect. An outbreak is an epidemic, but just in a specific geographic area. And a pandemic is an epidemic over several countries and continents. A pandemic has to come from somewhere. It needs a spark. Most viruses and bacteria which cause infection do not also cause devastation. But when a pathogen comes from a place we haven't evolved to deal with, our adaptations may fail and we can experience an unusually high impact. When a pathogen comes from animals, humans can't necessarily rely on our tried and true immune response to contain spread. The more we interact with and take advantage of the world around us, the more we are at risk of Mother Nature responding. Some ways humans expose themselves to environmental contagions are through hunting, animal domestication, eating wildlife, trading wildlife, and climate change. Once a new pathogen has introduced itself into the human ecosystem, it relies on a number of factors to spread. We are going to discuss a few concepts that allow for the spread of a dangerous disease. The environment, the life cycle of a pathogen, human behavior, the reproductive rate of a pathogen, and our response to the infection all factor into a pandemic's development. So I came to Kentucky from New England. I trained in Rhode Island. New England is Lyme disease country. In fact, the picture on the right was from my drive through Lyme, Connecticut during my move to Rhode Island. So on the map on the left, all of those dots, those are Lyme disease cases back in 2001. It looks like a solid line. So that's a lot of Lyme disease, right? Well, that was nothing compared to 2 decades later. Lyme disease spread north and westward at a pretty rapid rate. This is unquestionably due to climate change, allowing for a broader habitat of the Ixodes scapularis tick. But this is a pandemic lecture, and I'm fairly certain most of you have not heard of pandemic Lyme. So why haven't you heard of Lyme disease causing a pandemic? Well, Lyme disease is spread by the Ixodes scapularis tick, and it's spread to mice and to deer and to humans. Contracting Lyme requires a tick bite, and that tick needs to be infected with Borrelia burgdorferi. Lyme disease does not spread from human to human. Most people aren't getting tick bites often, but certainly climate change can alter that. So Lyme is a zoonotic infection, which is propagated by a changing environment, which are both risk factors, but the risk of encountering transmittable Lyme is low, so it never became a pandemic. The Black Death, a very vicious name, appropriately. It's one of the most notorious infections of all time, and it was caused by a bacteria called Yersinia pestis, which causes plague. The map shown displays the reach of the spread of plague in the mid-14th century. It encompassed all of Europe, much of North Africa, and Asia. So why was plague a pandemic? Bubonic plague is spread from flea bites, fleas that come from mice and from cats. In a city, especially one with poor hygiene and sanitation from the 14th century, these fleas can be most everywhere. The chance of a bite is high. In addition, humans can spread plague to each other via aerosolized droplets, and that's known as pneumatic plague. So between the fleas from the mice and the cats causing bubonic plague and human droplets potentially causing pneumonic plague, the chance of plague transmission seems pretty high. Now, in the mid-14th century, plague spread all throughout Europe. It spread faster than a human can travel, and humans weren't even traveling much compared to today. That being said, travel clearly propagates the spread of disease. In fact, air travel has an increase of fourfold in the last 30 years, and only seems to be increasing. The risk of any human-to-human transmitted disease greatly rises as people throughout the entire world are interacting. And we've seen this in the past. Even prior to air travel, travel has historically been a major cause of disease transmission. The red path shows the spread of leprosy, and the blue path shows the spread of smallpox, all from human exploration, migration, and trade. The earliest known evidence of malaria, which is shown in yellow, was in the region of what is now the Dominican Republic. It has spread to most of the tropical world by this point. Human travel spreading disease has shaped the way our history was written. Christopher Columbus, upon landing in Hispaniola in 1492, brought with his crew smallpox, measles, pertussis, varicella, plague, salmonella typhi, diphtheria, influenza, and cholera. Not really the best of guest appearances. 50 years after the arrival of Columbus, virtually all of the 8 million native Taino population were extinct. Humans, through interaction with animals, environmental influences, and travel, have propagated the spread of disease throughout history. Maps and retrospective data are helpful to see this, but we are providers, and we take care of patients. So let's look at a clinical scenario and figure out what factors go into infectious disease spread. So as a pediatrics resident in Alabama, I spent time working in a rural hospital in Rwanda. It was called Kibagora Hospital, and as Dr. Marshall referenced, an 80-bed pediatric inpatient unit. It sat on Lake Kivu, which is next to the border of the Democratic Republic of Congo. One of my patients during my time there was an 18-month-old male who presented with fever and diarrhea. He had retinal hemorrhages, and he had a lot of altered mental status. I diagnosed him with cerebral malaria after I saw his positive smear. During his stay, I noticed a rash on his abdomen, and it had been there for a number of weeks, according to his mother. It was not itchy, it was not painful. It spread very, very slowly. During my workup, I realized that his rash lacked pigmentation and was completely desensitized. Having an idea of what this was, given the very specific findings I saw, I asked his mom if anyone at home also had the same rash. And she said yes. In fact, his brother does. So I asked her to bring in the brother, and lo and behold, he had a diffuse, hypopigmented, and desensitized rash. I then find out that the patient's aunt is sick. She doesn't have the same rash, but she does have a different one, and it's becoming a problem. She is now seen as an outcast in her community. She's lost her job, all because people are afraid she may have a contagious infection. So I hope you can see this well because it's pretty impressive. But on the right is the patient's aunt. It was clear to me at the time, after many hours of looking at textbooks during my time there, that she had, and the patient had, and his brother had leprosy. I spoke to the local attending and told him of my findings. He said that can't be right because they don't have leprosy there. Well, these patients definitely had leprosy. So we ended up contacting the Rwandan Ministry of Health, who ended up using their leprosy task force to initiate large-scale treatment of the many contacts in their village who were subsequently diagnosed with leprosy. So leprosy spread through a whole village and people were not aware. How could this happen? Well, Mycobacterium leprae is a zoonotic infection, with armadillos being the natural host. But once it gets into the human population, leprosy can spread via human-to-human secretions. This is a setup for large-scale human spread, until you look at the incubation period. The incubation period of leprosy is from 1 to 20 years. Mycobacterium leprae only spreads after symptoms arise. It takes so long to incubate, and spread can be very slow. So if it is such slow spread, and so many people had symptoms in this village, then how was it not picked up sooner? Well, people were not looking for it. In resource-limited settings, there is often limited access to healthcare, and the focus is much more on severe acute medical problems than issues that frankly aren't life-threatening. In 1991, the World Health Organization issued a resolution to achieve global elimination of leprosy by the year 2000. They defined elimination as the reduction in prevalence of the disease to less than 1 case per 10,000 people. Although this target was achieved in 2000, many countries continue to experience transmission of the disease. So it's easy for a disease like this to fly under the radar because it had been reduced so much. Outbreaks that aren't picked up quickly typically can cause problems. This was an outbreak of leprosy, but clearly did not evolve into an epidemic or a pandemic. So how has it not become a global pandemic if it flew under the radar? Well, the answer lies in a mathematical variable called R0. R0 is the reproduction number. It uses serologic and epidemiologic data as well as theoretical models to calculate. Those models look at transmissibility of disease, they look at the human behavior, they look at the contact between sick and healthy people, and the models also factor in where an outbreak occurs geographically. In essence, R0 aims to tell us that for every person infected, how many people will the disease spread to? If R0 is less than 1, the disease will die out. And if it is greater than 1, it will spread. So the R0 of leprosy in armadillos is above 1, so it spreads easily in a population. But in humans, it tends to be less than 1, and it dies out. So the R0 of leprosy in humans is low. But what about other diseases? Here we have a picture of the R0 of measles, Ebola, and influenza. Measles, often considered to be the most infectious of diseases, has an R0 of up to 18, which means that for every person infected, they may spread measles to 18 other people. It spreads exponentially quickly. So why isn't measles everywhere? And that's because of something called R. R is the effective reproductive number, and this accounts for immunity in a population, namely previous protection or vaccinations. R equals R0 times X, and X is the percent of people who are susceptible to a disease. If R is less than 1, the disease can die out due to herd immunity. Measles is a great example of herd immunity and the success of vaccines. Measles is a disease with a high R naught and a low R due to vaccination programs. At its peak, the incidence of measles in the United States was about 1 in 100 people. Now it's only seen in sporadic outbreaks, mostly in an unvaccinated community. Now we know why leprosy wasn't a pandemic, but let's look at a more hypothetical model in a representative clinical scenario. Imagine you're seeing a patient in the Democratic Republic of Congo, maybe in Kinshasa, the largest city. Your patient has the same symptoms as our patient with leprosy. She's a 17-year-old female. She has fever and diarrhea. She has retinal hemorrhages and altered mental status. Well, you get very excited. You take her blood and you smear it on a microscope plate. You stain it with Giemsa and see Plasmodium falciparum parasites. Great, we have a diagnosis, cerebral malaria. Fits all the boxes. So you treat her with IV artesunate, but after 3 days, she develops coffee ground emesis, and she also develops hematuria. This seems a bit unusual for a course of malaria, especially on proper treatment. Well, maybe it's something else in addition to malaria. This could be something like yellow fever, which is endemic in the area. The map on the screen shows a large yellow area, and that's where yellow fever is found. Unfortunately, yellow fever can be quite fatal. On day 7 of illness, she develops melena and shock, and then she passes away. 3 days later, a few of her nurses are reported to be ill with headache, fever, and petechiae. It seems to be that her close contacts were sick, which indicates likely human-to-human spread. However, yellow fever is not transmitted by humans. It's transmitted by mosquitoes. So it's probably not yellow fever, but this could be something else that is spread person to person. The issue now, as we've delayed our diagnosis, is that we have people out in the community potentially infecting others. They may have gone to school, to stores, to family gatherings, really anywhere. We see this type of exposure and spread all the time during cold and flu season. But for every hour there is community spread, the number of infected people climb. With typical infections that we are used to handling, this scenario may not be so bad. But what if we are dealing with something more dangerous and a more unusual pathogen? This patient has some very concerning symptoms consistent with a deadly pathogen. Her symptoms are hemorrhagic in nature, and maybe we are dealing with something much more uncommon than malaria or yellow fever. Maybe we are dealing something such as Ebola. So if you think you have a case of Ebola, you definitely need to tell somebody about it. There are global surveillance programs just for this reason. And we have a surveillance program for a bunch of different pathogens, including Ebola virus. Internationally, we're looking for Sars and MERS and dengue, Marburg, avian flu, chikungunya. We have a bunch of domestic surveillance programs looking for agents of bioterrorism such as anthrax. And global surveillance is great, but it really relies on cooperation and trust. There is no central governing body for global disease surveillance. Pandemic response must be coordinated amongst organizations that have mutually decided to work together. And if there is a lack of country-specific participation, if a country decides not to be involved, the only repercussion is bad health outcomes. It's the same with domestic surveillance. The CDC relies on providers and microbiologists to alert them to potential emerging pathogens. The CDC utilizes different domestic networks, such as the Emerging Infections Program, which is a national network for population-based surveillance and research. They use something called the National Molecular Subtyping Network for Foodborne Disease Surveillance, and that's where you see all the alerts of food recalls from different grocery stores. They even have a gonococcal isolate surveillance project to look for antimicrobial resistance in Neisseria gonorrhea. And once a pathogen is identified, once it's brought to the CDC or another country-specific program, the CDC then has to go back and tell the other local public health officials. Each country has their own method of communicating with local agencies, and there are a lot of moving parts. The CDC in particular uses something called the Epidemic Information Exchange, which is a secure method of sharing health surveillance information on outbreaks and other unusual events. They also have something called the Health Alert Network, which links local, state, and federal health agencies and provides an electronic platform for emergency alerts and long-distance training. In Europe, there's something called the Early Warning and Response System, and globally, the WHO shares information through something called Disease Outbreak News, which is on their website. So back to Ebola virus. In December of 2013, there was an 18-month-old male in Guinea who contracted Ebola virus disease after a bad exposure. This one's a true story. From 2014 to 2016, Ebola spread in West Africa from Guinea to Liberia and to Sierra Leone. There were cases that reached Europe and even North America. So if we have global surveillance, why did it last so long, and why was it not contained? Well, to respond to an Ebola virus outbreak, a strong infrastructure and a unified message is needed. That did not occur as the health systems weren't prepared. Culture and politics hindered the response, and there was not direct messaging about what to do, and people were focused on surviving life in general. They were not focused on surviving an unusual pathogen such as Ebola. The epidemic of Ebola virus became a disease of poverty. Countries with resources were able to stop the spread of disease, and areas with low resources were not. Fast forward to 2021, from February to June of this year, there were 16 cases of an Ebola virus disease outbreak and 12 deaths. So a large vaccination response was implemented. We have 2 vaccines available for Ebola virus disease, one from Merck and one from Janssen. So how do we use these vaccines effectively, and what are the strategies for future outbreak vaccination programs? Since the 1970s and the discovery of Ebola virus, there has been less than 30 outbreaks and less than 40,000 cases. But the area where Ebola is endemic comprises 500 million people. So with so many people and so few outbreaks, it can be tough for a low resource area to justify the cost of routine vaccination in a depleted health system. But outbreaks are clearly devastating. They have massive health and economic burden. There are strategies we can try for vaccination other than just vaccinating everyone, which is ideal. One approach is vaccinating hotspot areas, places likely to have outbreaks. This is not ideal because Ebola outbreaks have a complex ecology. They are difficult to predict. Typically, outbreaks don't happen more than once in the same discrete area, and human influences are always a major wildcard. A well-known and utilized strategy used in previous Ebola outbreaks was something called ring vaccination. This is where cases are identified and first and second degree contacts are all immunized. The problem with ring vaccination is that cases must all be identified, and they must be identified very quickly, or else the pathogen escapes the ring. It can also be difficult to justify to others why some get the vaccine and some do not. This model has stymied some spread in the past, but has been slow to completely stop it. So we've discussed vaccinating hotspot regions and ring vaccination, which has pros and cons. The most effective method is probably a combination of both of those two, as well as vaccinating high-risk individuals, such as healthcare and frontline workers. A potential strategy includes vaccinating sex partners of survivors, as Ebola can be sexually transmitted after recovery. An important step would also be to initiate outbreak vaccination campaigns, which may help create a strong community response to vaccines. And then when it's all said and done, we'd want to vaccinate as many people as possible in that region, even after the outbreak is over. In terms of outbreak response, there are surveillance and vaccination techniques that we've just discussed, but there are also specific treatments and public health measures that are very pathogen specific, so I won't go into detail into those today, but they do play an enormous role in how a pandemic evolves. So I avoided talking about it up until this point, but now we must discuss how all of this plays into SARS-CoV-2. But before SARS-CoV-2, we've actually seen another coronavirus epidemic. In 2003, SARS-CoV-1, which resulted in 8,000 cases and almost 800 deaths, was considered to cause more fear than any other outbreak of the time. It did not become a global pandemic the way SARS-CoV-2 did, in part because of public health measures like surveillance and isolation. But the major difference was that there was no asymptomatic transmission of SARS-CoV-1, and the severity of disease strongly correlated with infectivity. But we knew that if it could spread prior to symptoms, it'd be much more contagious. In 2003, SARS was a wake-up call, and it led to a revision of the international health regulations and development of the global health security agenda, which includes 70 countries. Then, when the 2009 H1N1 swine flu pandemic came along, there were many panels and recommendations created to improve pandemic preparedness. Well, all of that led to little change, and most recommendations never made it beyond the paper they were written on. Since 2003, we've had SARS, swine flu, MERS, Ebola, and Zika to stoke preparation, but the global community continued to fail at this task. Now we are dealing with SARS-CoV-2 and COVID-19. We've seen about 150 million infections, now almost 200 million as of a couple days ago, and more than 3 million deaths. More than 17,000 healthcare workers have died in the first year. This has been the largest hit to the global economy since World War II, and the greatest economic contraction since the Great Depression. It has been due in large part to a lack of preparedness. And it wasn't that countries didn't think they were prepared, they just weren't prepared. Country preparedness was assessed under a voluntary, independent academic exercise called the Joint External Evaluation Process. Here on the y-axis is death rate due to COVID-19, and on the x-axis was the preparedness score calculated by a country's own internal evaluation metric. What is shown is that the ranking of a country's preparedness did not predict the performance of those countries in the COVID-19 response. Highlighted in the box, you can see that the US is far to the right and high on the evaluation score, but also high on the y-axis, meaning a high death rate. The measures implemented did not account sufficiently for the impact of political leadership, trust in the government, and the ability to mount a fast and adaptable response. All that to say, the US scored high for being prepared, but still had a very high death rate. So we know the world was not prepared. The inability to take preparation seriously, combined with population growth, environmental changes, and global travel, put the world at risk for a zoonotic infection to be introduced into the population. Which brings us to December of 2019. There was an unknown pneumonia discovered in Wuhan, China. From December 16th to January 2nd, 41 patients diagnosed with what now is known to be COVID-19. Almost 2/3 of those cases had been in Hunan seafood market in Wuhan. We still do not know if the market was the origin of the virus or a site of viral replication and transmission. During December, it was unclear if the virus could be transmitted human to human. By January of 2020, it was very clear this is what was happening. On December 30th, 2019, the Wuhan Municipal Health Commission issued 2 urgent notices to hospital networks in the city about cases of pneumonia of unknown origin linked to the Hunan seafood market. The market was closed and cleaned from December 31st to January 1st. The Taiwan CDC then alerted the WHO through the International Health Regulations Reporting System. Very quickly, on January 2nd, SARS-CoV-2 genome was sequenced and then made public on January 11th. A PCR test was created by January 10th. This rapid response was all due to astute clinical teams. On January 2nd, the WHO went to investigate in Wuhan. On that same day, China confirmed that the virus is transmitted from humans to humans. On January 23rd, China went into lockdown. But 10 days before the lockdown, Thailand had seen their first case and it already started to spread. A public health emergency of international concern, or PHEIC, is the loudest alarm that can be sounded by the WHO Director General. The meeting of the WHO International Health Regulation Emergency Committee called to discuss the outbreak on January 22nd and January 23rd, but was split on whether to recommend that the outbreak be declared a PHEIC. The committee met again the following week and recommended declaring a public health emergency of international concern on January 30th. At that time, travel restrictions were not recommended. Then, on March 11th, COVID-19 was declared a global pandemic. Throughout this whole process, data sharing moved very fast, but action to declare an emergency moved very slow. The problem is that highly transmissible respiratory infections do not wait around for decrees of public emergency to be called. On January 30th, the spread of COVID-19 was limited to the darkened areas you see on the map. By March 11th, when COVID-19 was declared a global pandemic, the map became mostly red. The first case in the United States was in a person who arrived on January 15th, 2020, and tested positive 6 days later. By the first week of March, the epidemic in the United States was doubling every 2 to 3 days, suggesting rapid, uncontrolled spread. On March 13th, the government declared the pandemic a national emergency. Countries with less deaths per capita took precautions earlier to prevent community transmission. They bought time to collect information and developed a cohesive approach. For many countries, it was not until they had already seen widespread local transmission and their hospitals were starting to fill with desperately ill patients that they finally took action. Healthcare facilities all around the world were not ready for such spread. Ambulances were waiting in line to reach emergency departments that were too full. And once in the hospital, patients had to wait in EDs as inpatient beds were in short supply. There are many examples of systems that were many times over capacity. As the pandemic developed, personal protective equipment became needed in quantities not seen before. The world needed 40% more PPE than could be produced. Remember back to a year ago when we were considering using homemade masks in hospitals. And PPE became expensive. The dark bars are pre-pandemic prices. The pink and the red bars are the average and maximum prices of PPE during the early stages of the pandemic. High prices leads to loss of access, and loss of access leads to inequity. As you all know, healthcare was not the only part of society that had a problem to deal with. Most businesses and infrastructure was not able to adapt to a pandemic environment. Almost 75 million people in the United States who were at risk for severe COVID did not have a job that would allow for working from home. People had to choose between safety and being able to provide for their families. Being able to stay safe while not starving became a privilege, and it further drove institutionalized inequality. Inequity was and is clearly magnified during the pandemic. Worldwide, nearly 125 million people are living in poverty directly as a result of the pandemic. Because of lack of resources dedicated to an adaptable learning environment, an estimated 90% of students will suffer irreversible educational deficit. The inequity rift has focused more on females, underrepresented minorities, and the underprivileged. Globally, many females are at increased risk of never returning to school. 10 million females are now at risk for early marriage due to the pandemic. There has been a sharp increase in gender-based violence. Women have lost jobs at a much higher rate than men. 39% of the global workforce are women, and 54% of newly unemployed women are newly unemployed women. Poverty and inequity are hitting hardest those who were already disadvantaged: females, minorities, the impoverished, and children. As said succinctly by the leader of the Shipibo Konibo community, if COVID doesn't kill me, hunger will. In America, we saw a rapid rise in food insecurity, and it particularly hit our children the hardest. Poverty and school closings played a role in depriving children of consistent meals. Child food insecurity rose from 15% to 25% in the early stages of the pandemic in the United States. But science does work, and we as humans can show resiliency. As of August 4th, 2021, there have been 19 COVID-19 vaccines with either full authorization or emergency use approval. All of this in a very short period of time. This chart shows a timeline of when a disease was discovered to when a vaccine was licensed in the United States. The leftmost side dates all the way back to 1880, and the right side is in 2020. The bar length is the time from discovery to licensure. COVID-19 is highlighted on the bottom. The vaccine development has been remarkably efficient and thorough. I will not get into vaccine specifics during this lecture, as Dr. Statler, Dr. Barton, and myself discussed this during Grand Rounds in April. But the message is clear. The COVID-19 vaccine development has been one of the most, if not the most, impressive displays of global science the world has ever seen. Unfortunately, not everyone has the privilege of taking advantage of science's hard work. The darkened areas on the map show high rates of COVID-19 vaccination per capita, and the light area show low rates. It is clear that rich countries are getting vaccinated at a much higher rate than poor countries. Even with our own country, vaccine rates differ greatly based on demographics. A lot of this inequity is due to access to medicine, but not all of it. Much of the struggle to achieve a global vaccination comes from vaccine hesitancy and the spread of misinformation. We are watching science develop in real time, and so is the general public. Science can be confusing to many, and especially so when science is politicized. There are many places people get information from. Most people genuinely want to do what's right for them and for their family. However, unfortunately, the easy choice of listening to the data is difficult when people hear mistruths. Politicians, social media, word of mouth are all sources of misinformation. People's beliefs are shaped by these sources. But beliefs are just beliefs, and science is what we need to spread. We, as scientists, need to make it clear that we are following the data. As Dr. Virchow said, belief begins where science leaves off and ends where science begins. Oh, look, it's another Virchow quote. He was a wise man, wasn't he? Medicine is a social science, and politics nothing but medicine at a larger scale. So what can we do to prepare for the next pandemic? Well, we can get our policymakers on board with listening to science. They must not let alternative agendas get in the way of public health. Dr. Virchow realized that we cannot differentiate the medical science from social ecosystems. Because as science interacts with social and geographical and geopolitical boundaries, it is slowed down. The virus has time to evolve, and it has time to become more difficult to treat. The graph that looks like abstract art that you see on the screen represents the quickly evolving phylogenetic tree of SARS-CoV-2. Each dot represents a mutation of SARS-CoV-2. On the left is December in 2019, and we start with the original SARS-CoV-2. On the right, we come to the summer of 2021 with more dots representing mutations than I care to count. Right now, the Delta variant is the predominant strain in the United States, as seen in green on this graph. We have seen a large and swift uptake in cases as a direct result of inadequate vaccination numbers, as well as the mutation of the virus into a more transmissible strain. So what can we as an individual do? Luckily, we have a response to the evolving virus, and it comes from examples of basic scientists and physicians working on research. This pandemic has taught us a lot of things, but one thing that has been made very clear is the need for contribution in research to come from many areas. Dr. Catalin Carrico has been working on mRNA vaccines since the mid-1980s and before they were very well known. Her ideas were initially trivialized, and she had to move from academic lab to academic lab as she was focused on her goal. She was a pioneer in a field that had no fanfare. This is why basic research is important. Without her, we would not have developed mRNA vaccines. Our mRNA vaccines are one of the most adaptable tools ever developed against an evolving infection. Louis Pasteur once said that chance favors the prepared mind. And this is a wonderful example of how all scientific contributions, no matter how seemingly minor at the time, have potential to be game changers. But let's say you're not a basic researcher. What can you do as a physician or scientist to prepare for the next pandemic? We can all become public health advocates. Sure, we all know Dr. Anthony Fauci, and in my last home in Rhode Island, Dr. Nicole Alexander Scott, the director of the Rhode Island Department of Health, was a local celebrity. But most people do not know scientists outside of a select few famous ones. And most people's only avenue to learning science is through their physician. We as physicians must dedicate ourselves to proper scientific messaging in our communities. People tend to trust their medical providers. People tend to trust us more than many other professions considered to be leaders. The graph shown depicts public confidence in different fields of service, including the military, teachers, religious leaders, the media, business leaders, and elected officials. Confidence in medical scientists have garnered the highest marks. We have a lot of power, but we also have a lot of responsibility. So today I hoped we all learned how an outbreak becomes a pandemic and what factors lead to what we are dealing with today. Infectious disease catastrophes depend on the etiology of the pathogen, the ability of an infection to spread within a global realm through susceptible populations, travel, and climate change. Our response to these pathogens through surveillance, medical treatments, and public health measures can mitigate or propagate their spread. Perhaps most importantly, a world of inequity is a world at risk. But we have tools to prepare for next time, and there will be a next time. We need to invest in preparedness. Here at Norton, we are getting our infectious disease unit up and running in order to prepare in case of a high-risk transmittable disease outbreak, such as Ebola virus. We need strong leaders who believe in science. We must protect our environment. We need to have a unified public health response. We must protect those most at risk. And as a medical provider, we must teach our patients and our community the best we can. Perhaps the best summation quote I've seen regarding the COVID-19 pandemic came from Melinda Gates. She said, "This pandemic has magnified every existing inequality in our society, like systemic racism, gender inequality, and poverty. And it's impossible to pick one issue as more serious because so many people live at the intersection of all of those challenges." And I agree. Thank you very much. Let's see.
Thank you so much, Dr. Blatt. We have a few minutes if anybody has any questions that they would like to ask.
Well, I appreciate you guys all listening to me for the last hour, and I really hope we can have grand rounds in person soon.
Dan,
I do have a question, Dan.
Okay.
Oh, sorry. If someone else has one, go ahead.
Well, no, this is Dr. Marshall. Dan, thank you really so much. That was just eloquent and very thought-provoking and scary. And I'm glad we have bright young people to take the lessons from what we've learned from COVID-19 and move them forward. So thank you again.
Happy to be of service, and I'm happy to be part of this community. It looks like there's a question I'm talking about vaccine hesitancy with adolescents. And that's a great question. It's something we're dealing with in droves today. Again, there's a lot of misinformation out there. I think adolescents are probably the best people to talk to. And the reason I say that is because they influence the younger generation as well as their parents. Adolescents are thoughtful and they care. And they're not necessarily the same people as their parents. And so talking with adolescents in earnest is the way to help. And what I mean by that is if you tell an adolescent that by getting vaccinated, they not only will help themselves, but they will protect their friends, I think that's the most effective way. Adolescents just care about their friends. They are good people. They haven't been weathered by the world nearly as much as adults in general. And so I think they're much more impressionable, especially from people who have authority, such as physicians. You know, now is the time when they're most impressionable, and we really need to get to them before someone else does. So I think we just need to show that we care, and that by them getting vaccinated, they also care.
Dan, I'd certainly reinforce what you just said and all the things that you said. In fact, with the public trusting physicians is important. The target group that we're talking about, adolescents, are the least likely to have contact within the pediatric population. Once kids hit middle school and high school, their parents are less likely to take them for routine medical care. And the other inequity that you talked about was poverty. So people from impoverished neighborhoods are less likely to have physician contact unless it's in an emergency room or an ICC. So, you know, the public health measures we can do to try and get, you know, more physicians who adolescents may trust into the middle schools and high schools to talk about the importance of healthcare and vaccination would be a real challenge for Norton Children's Medical Group.
Absolutely. Access to care is one of, if not the most large barriers that we have to overcoming not just this pandemic, but pretty much every healthcare issue. And like I said before, the only way through a pandemic or through any public health crisis is really equity amongst healthcare and efficiency amongst healthcare. So you're right, there's a lot that needs to be invested in this, and it starts with places like Norton or any medical community. Dr. Kim was asking about new variants and that we should be concerned about. Well, as I showed on the map before, that a lot of the world is not vaccinated. New variants definitely have a strong risk of emerging. And they will continue to do so the more people that are infected. As someone's infected, the virus has a lot of time to mutate. And sometimes those mutations are more infectious or more deadly, or they evade vaccines. And so there are definitely some variants of concern that are being watched in the global surveillance programs. We send a certain proportion of our positive tests to be genotyped and to look for different variants of concern. Right now in the news, you'll see something not only besides the Delta variant, but you'll see things about the Lambda variant as a variant of concern. So there are new ones popping up all the time, and we just need to stay up to date. But really, the one we're dealing with right now in the US is the Delta variant. Dr. Knapp said, what are factors that contribute to governmental and other institutional unwillingness to invest in proper preparedness measures, both here in the US and in other countries? Well, that is a great question. And I don't have a very succinct answer other than to say it's a problem, and it probably has to do a lot with not caring for people who are poor and systemic racism, and not caring for really our fellow man as a whole. Governments are very fallible, and I do think that it's tough for a government to make proper medical decisions when most of the government is not public health officials. And any other questions? Any recommendations on the role of monoclonals in the management of early SARS-CoV-2 in teens? So there is constantly evolving recommendations on monoclonal antibodies, especially now that we have the Delta variant running around. Monoclonal antibodies have been proven to be very effective in preventing the progression to severe disease, even in teenagers, and especially teenagers at risk. I do a lot of transplant peds ID, and all of our patients are at-risk patients. And so people who are exposed and at risk are definitely candidates to get monoclonal antibodies, and people who have the disease are also candidates. And so those recommendations are constantly changing literally every day. The EUA just changed a few weeks ago, incorporating post-exposure prophylaxis for those who are immunocompromised. And so the best way to do it is just look at institutional guidelines and ask your fellow PEDS ID doc what their recommendations are at that time. But in general, high-risk patients probably need to at least think about monoclonal antibody treatments.
And Dan, I would just add, and most of you know this already, but the pathway to monoclonal antibody infusion is through evaluation by the infectious disease service. So if you have patients who you think meet the minimum criteria to consider treatment, just call our office and we will arrange to have a virtual outpatient evaluation, and we will help you together, decide whether treatment is indicated.
So my good friend from residency, Dr. Brian Gavin, who's a pediatrician in Alabama, just wrote a question. I hear from a lot of patients that COVID vaccine came out too fast, and that worries them. How do you answer that? Well, Brian, that's a long answer, but I'll try to do my best to do it quickly. And as I said before, the mRNA vaccines have been in development since the 1980s. So we have been working on this for decades, and we were just waiting for the opportunity to use it. We have more data on the COVID vaccines than almost any other medical intervention that's out there. We have hundreds of millions of people that have gotten the COVID-19 vaccine, and we have data on a lot of them. So we really know that this is a safe and effective vaccine. I think the messaging is wrong, and that this did not come out quickly. This has been years in the making, and it just was implemented quickly. Well, it was a pleasure spending time with you guys today, and I hope to do it again soon. Thank you so much.
Thank you so much, Dr. Blatt. As a reminder, the CME code for today was 130403. Everybody have a great day. Thanks.